Hey everybody, welcome back for another deep dive. This time we are all up in the ICD-10-CM Chapter 2 Guidelines for Neoplasms.
Oh, yeah.
We've got some excerpts from the Neoplasm Guidelines to help us sort it all out.
Fun stuff.
And if you want a little bit more help navigating these things, don't forget to check out the MCG Manual by Absolute Medical Coding Institute.
Yes.
We'll link it in the description. It's a really, really useful tool.
Absolutely.
So yeah, we're talking about neoplasm.
Neoplasms.
Which basically boils down to how do you code for tumors, benign, malignant, all that good stuff.
All sorts of growths.
Growths. So this is going to be fun.
Yeah, this is one of the areas in coding where I think it's really fun because the guidelines are constantly evolving.
Oh, really?
As medicine kind of discovers new things about cancer and different treatment modalities.
Right.
It's not just rote memorization. It's like we really need to understand the logic behind it and be able to apply it to these new situations as they arise.
It's really important. So we're looking at Chapter 2, and it covers most benign neoplasms, but not all of them.
Right. So you will see that there are some benign neoplasms, like, for example, a benign prostatic adenoma is actually categorized in the chapter specific to the male genital system.
Right.
But for malignant neoplasms, this is the place to be.
This is it. This is home base.
Home base.
Okay, so.
And before we even get to the codes, right, we have to understand what we're even talking about. Yeah. What's the difference between a benign neoplasm and in situ neoplasm, a malignant neoplasm, a neoplasm of uncertain behavior?
Yeah. What does all that even mean?
What does that even mean?
Before we even get to the codes.
Yeah. Right, and that really guides our coding to make sure that we're selecting the right codes.
Now, one of the things I always think about when we're talking about malignant neoplasms is secondary sites.
Yes.
Metastasis.
Metastasis.
So how does that, how do we work with that?
That's a great point because,
in the code,
you know, if someone has, say, lung cancer and it's spread to the liver, we're not just coding lung cancer, we're also coding that liver metastasis.
Right.
Because that's important to be able to understand the full extent of the disease and how complex the patient's condition is.
Yeah, it's like putting a puzzle together. You need all of the pieces to get the full picture.
Absolutely.
So where do we even begin to find these pieces? We've got all these guidelines. Where do we start?
Well, we need to navigate the Neoplasm Table in the alphabetic index.
Okay.
And this is really our roadmap to accurate coding.
Talk to me about the table.
So it's a two-step process.
Okay.
The first thing is you're going to reference the table itself, which organizes neoplasms by anatomical site.
Okay.
Then you're going to look for the histological term documented in the record.
Okay.
Like, you know, adenoma, carcinoma, whatever it may be, and pinpoint your code. But here's the catch.
Okay.
We don't stop there. We verify that code in the tabular list.
It's a double-check system.
It's a double-check system.
Right.
Because there might be instructional notes that provide additional information.
So making sure we're being as specific as possible.
As specific as possible.
With the right code.
Absolutely.
Okay. So let's say we found the right code.
Okay.
How do we apply it in different clinical scenarios?
Right.
So, for example, what if a patient is admitted for treatment of a secondary malignancy?
Okay.
Like, let's take that liver metastasis that we were just talking about.
Absolutely.
Does the primary malignancy code still come into play?
That's a great question.
If the focus is on the secondary site.
So even if that primary malignancy still exists, the code for the secondary malignancy is going to take precedence in this scenario and become the principal diagnosis.
So it really is all about the context.
It's all about the context because in this case, the secondary malignancy is driving the treatment plan.
Okay. All right. That makes sense.
Yeah.
Now, the guidelines even go into talking about complications related to malignancies like anemia.
Yes.
So how do those impact the coding?
So anemia in the context of malignancy is interesting because it can be caused by the disease itself or by treatments like chemotherapy.
Okay.
So if it's malignancy related, the malignancy code comes first, followed by the anemia code.
Okay.
If it's treatment related, the anemia code leads, followed by the malignancy and any adverse effect codes.
Oh, so we're really,
for example,
establishing that.
If someone has anemia
that connection
due to chemotherapy for leukemia, that sequencing would be anemia first, leukemia second, and then the adverse effect of the chemotherapy.
So we're really connecting the dots.
Connecting the dots.
Of the malignancy, the treatment, and the anemia.
Absolutely.
Okay.
And this isn't just, following the rules. Yeah. This has real-world implications because it can impact reimbursement rates.
Oh, wow.
And the accuracy of clinical data
Interesting.
that's used for research.
So it goes beyond just...
It goes way beyond.
Getting the code right.
Absolutely.
Wow, okay. So we've got anemia. What about other complications? Dehydration.
Yes.
Pathological fractures.
Absolutely. So for dehydration, if it's a direct result of the malignancy, then the dehydration code leads.
Okay.
Followed by the malignancy.
Got it.
For pathological fractures, it depends on the focus of treatment.
Okay.
So if the fracture itself is the primary concern, then the fracture code takes precedence. But if the treatment is targeting the underlying neoplasm, then the neoplasm code comes first.
Okay, so it's all about the nuance.
It's all about the nuance.
Of each case.
Absolutely.
And making sure that we're applying the guidelines appropriately.
Correct.
Okay.
Now, what happens if that primary malignancy has been surgically removed and there's no evidence of current disease? Does it just vanish from the coding?
Right, because they still have a history of
Well, exactly. So that's where the Z85 category comes in.
Okay.
We use a Z code from this category to indicate a history of malignancy.
Okay.
Even after that primary site has been excised.
So it's almost like a little...
It's a way of acknowledging that past diagnosis and making sure that it's not lost.
Okay.
In the patient's medical record.
So that any future providers are aware of that history.
Exactly.
Okay. All right. So let's move on to some of the big guns here.
Okay.
Chemotherapy, immunotherapy, radiation therapy.
The behemoths of
this could be
cancer treatment.
Oh, this could be such a coding nightmare.
Oh, yeah.
Right? Because there's so much to consider.
Yes.
When are we administering it?
Yeah.
What type of therapy is it? Is it part of a surgical procedure?
So it all comes down to one key question.
Okay.
Are these treatments being administered during surgery or as standalone encounters?
Okay.
If they're part of the surgical procedure, then the malignancy code reigns supreme as the primary diagnosis.
Got it.
But if the patient is admitted specifically for these therapies, then the Z51 code category for encounter for antineoplastic therapy steps into the spotlight, followed by the malignancy code.
So if they're having surgery for lung cancer, and they have radiation therapy at the same time, the lung cancer is...
The lung cancer code would be the primary.
The primary. But if they have lymphoma and they're being admitted just for chemo...
Then that Z51.
Then the Z51 comes first.
For chemo would come first, followed by the code for the lymphoma.
Okay, got it.
Okay.
Now, what if they experience complications from these treatments?
Complications add another layer of complexity?
Of course they do.
But the logic remains consistent.
Okay.
If a patient develops a complication due to chemoradiation or immunotherapy, then a Z51 code for the encounter for that specific therapy comes first.
Okay.
Followed by specific codes for the complications themselves.
Okay.
So, for example, if a patient develops dehydration due to radiation therapy, we'd sequence the code for radiation therapy first.
Okay.
Followed by the code for dehydration.
So again, connecting the dots.
Connecting the dots.
Of treatment complication.
Absolutely.
And patient condition.
It's like a coding chronicle documenting their journey.
I like that. I like that. So we've gone through so much. We've done the basics. We've looked at some complications and some treatments.
We've talked about history of...
What else is there?
Oh, my goodness.
What are some other weird scenarios?
There's just so many twists and turns.
That we might encounter.
In the world of neoplasm coding, we haven't even touched upon malignancy during pregnancy. Multiple primary malignancies.
Oh, fun.
Or those enigmatic cases where the primary site remains a mystery.
Okay, well, I think we need to take a little break.
Let's take a break.
And come back for part 2 because I have a feeling it's going to get a little
more complicated.
A little more complicated.
A little more in depth.
A little more in depth. Stay tuned.
Welcome back to our deep dive.
I feel like we could do a whole deep dive just on neoplasms.
Oh, absolutely.
There's so much to it.
Yeah, we could probably do like 10 episodes on this.
Right. It's fascinating.
Yeah.
So before the break, you had mentioned malignancy during pregnancy.
Yes. That's a big one.
That seems
a very specific scenario.
Complicated.
Yeah.
How do we even approach that from a coding standpoint?
Well, the guidelines do provide us with a clear path.
Okay.
So when a patient is pregnant and also has a malignancy, we use a specific code from the 09A category to indicate that the malignancy is complicating the pregnancy. And this code takes precedence, followed by the code for the specific type of cancer.
So let's say, for example, a pregnant woman is diagnosed with breast cancer.
Right.
Would we use the 09A code first and then the breast cancer code?
Okay.
So we're essentially creating like a layered code that reflects both the pregnancy and the malignancy.
Wow, it's amazing how specific these codes can get.
Very, very granular.
Yeah. So what about those cases where a patient has multiple malignant neoplasms in different non-contiguous sites?
Right.
How do we...
That could be tricky.
That just sounds like a coding nightmare.
Yeah, because in those situations, we really need to determine, are these tumors separate primary malignancies or are they representing metastatic disease?
Okay.
And this often involves, really digging into that clinical documentation.
Right.
And even, sometimes consulting with the provider for clarification.
So it's not just about, blindly applying codes.
No.
We have
There's detective work.
Really look at what's going on.
It is absolutely.
And understand it before we even start coding.
And that's so important because, accurate coding, it's not just about reimbursement.
Right.
It's about research. It's about public health initiatives. All the data.
That rely on good data.
Robust data.
Absolutely. So now let's talk about those cases where a patient presents with a widespread disseminated malignant neoplasm.
Okay.
But no primary or secondary site can be identified.
Right. So something's going on.
Yeah.
But we don't know where it started.
Right. It's a mystery.
Right.
So how do we handle that?
So in those situations, we would use a specific code, C80.0, for disseminated malignant neoplasm unspecified.
So it's almost like a placeholder.
It's a placeholder.
While we try to figure it out.
It's acknowledging that, hey, there's widespread malignancy going on.
Right.
But we don't have enough information to pinpoint where it originated.
Okay.
And it's really capturing the essence of the patient's condition.
Right.
Even when we don't have all the detail.
Okay. What if we never figure out the primary site?
So for those truly perplexing cases, there's a code for that.
Of course there is.
C80.1.
Okay.
Malignant neoplasm without specification of site.
Okay.
So this is very rarely used.
Right. In inpatient settings.
Hopefully we figure it out.
Usually with diligent investigation, you can determine that primary site.
Okay.
But, there are those occasional cases where it remains a mystery.
Right. So it really is a last resort code.
It's a last resort.
Okay.
When we've exhausted all other avenues.
All right. So let's switch gears a little bit and talk about complications that can happen during neoplasm treatment.
Right.
We touched on it a little bit before, but I think it deserves a little bit more.
We did touch on it.
Attention.
Briefly, but it's important to really...
Yeah, because these complications can have a big impact on patient care.
Absolutely.
So how do we really make sure we're coding them properly?
So when we encounter these complications, right, the coding focus shifts.
Okay.
So the code for the specific complication becomes the principal diagnosis.
Okay.
With the neoplasm code playing a supporting role as a secondary diagnosis.
Okay.
So, for example, if a patient develops a post-surgical infection after a lumpectomy for breast cancer, that infection code would be the star of the show, with the breast cancer code kind of providing the backdrop.
So really,
So we're capturing that full spectrum
highlighting
of the patient's experience.
Your complication.
Acknowledging those complications that can arise during their cancer journey.
Right. Now, we talked about pathological fractures before.
Yes.
And I think it's worth revisiting that in this context of complications.
Yeah, absolutely.
Because I remember we talked about how the sequencing depends on whether the focus is on the fracture itself or the underlying neoplasm.
Exactly.
So can you refresh my memory a little bit on that?
So if the primary aim of treatment is stabilizing the fracture itself, then the fracture code takes precedence.
Okay.
But if the treatment is geared towards managing the neoplasm that caused the fracture, then the neoplasm code comes first.
So if a patient has a pathological fracture due to bone metastases, and they're just treating the fracture itself, then the fracture code is primary. Okay, but if they're treating the bone metastases, then the neoplasm code
is the primary. Okay,
so
again,
it all comes down to understanding that clinical context and the goals of treatment.
It's all about the context.
It is.
Okay. All right, so now let's talk about some special cases that require extra attention. When coding for neoplasms.
Okay.
First up, leukemia, myeloma, and plasma cell neoplasms in remission.
Ah, remission.
How do we?
That's a positive milestone
Yes.
in a patient's cancer journey, but it does introduce some coding complexities.
So how do we handle that?
So we use special codes that are designed to indicate that the patient is in remission. Again, it's really important to consult that tabular list and carefully verify that the code that you're choosing aligns with what the provider has documented.
And if we're not sure,
if there's any ambiguity, query the provider.
Right. So if a patient has multiple myeloma in remission, we're not using the code for active multiple myeloma.
We're using the code for...
We're going to use that code for multiple myeloma in remission.
Okay, got it. All right.
It's all about precision, right?
Precision.
Making sure that our coding accurately reflects the nuances.
Now let's talk about breast implant-associated anaplastic large cell lymphoma.
BIA-ALCL?
That one always gets me.
Yeah, that's a mouthful.
BIA-LCL.
It is a mouthful, and it's a relatively new diagnosis that often stumps even experienced coders.
So how do we code for that?
So for BIA-ALCL, there are specific codes that have been introduced.
Okay.
And it's really important to consult the latest ICD-10-CM coding guidelines to ensure accuracy.
Because they do change.
And a key factor in determining the correct code is the presence or absence of a breast implant.
Oh, okay. So if a patient has BIA-ALCL and still has the implant, it's a different code than if the implants have been removed.
That is correct. So again, paying close attention to the documentation, making sure our coding aligns with the specific details of the patient's case.
It's all in the details.
It's all in the details.
All right. Last but not least, we need to talk about secondary malignant neoplasms of lymphoid tissue.
Yes.
These can be tricky too because they involve so many different sites.
Absolutely. They can involve a variety of sites within the body.
So how do we approach that?
So when coding for these secondary neoplasms, we're using codes from the C81, C85 range.
Okay.
But focusing on those that refer to extranodal and solid organ sites.
Okay.
So really pinpointing the specific site of that secondary neoplasm and selecting the appropriate code to reflect its location.
So for example, if a patient with non-Hodgkin's lymphoma develops a secondary neoplasm in the liver, we would use a code from that range.
From the C81, C85 range.
To
indicate that liver involvement.
Okay.
Again, it's about that precision, making sure our coding tells a complete and accurate story.
So we have covered so much.
I know.
It's amazing. I feel like I'm already
a lot to digest.
So much better at neoplasms.
We've really journeyed through a coding labyrinth today.
We have.
Haven't we?
Right.
From the basics of neoplasm classification to the complexities of these special cases.
Right.
I mean, we've really covered a lot of ground.
But there's always more.
But you know what?
Right.
Our exploration isn't over yet.
Of course not.
There's one more crucial aspect
of
neoplasm coding that we need to discuss.
Yeah, me.
And that's the ever-evolving nature of these guidelines.
Okay.
And the importance of staying up to date.
I was just thinking that.
Because, you know, the world of oncology is constantly advancing.
Right. New discoveries all the time.
With new discoveries and treatments.
New treatments.
Yeah.
How do we keep up with all that?
That is a great question.
Yeah.
And that's what we're going to delve into in our final segment.
Okay.
So stay tuned because we're about to wrap up our deep dive with some key takeaways and insights.
Can't wait.
To help you navigate this ever-changing landscape.
I'm ready. All right, so we're back and ready to wrap up this neoplasm coding extravaganza.
I think we've covered just about everything you could possibly need to know.
Yeah, we started with the basics, you know, benign, in situ malignant, all that good stuff.
Those foundational concepts are crucial.
Yeah, and then we jumped into the Neoplasm Table and the tabular list.
Our trusty coding companions.
Always double check.
Always double check.
Make sure we're getting the most specific code.
Absolutely.
Then we went through all sorts of scenarios, secondary malignancies, complications, treatments.
We really dug deep into those clinical nuances.
We did. It's amazing how much context matters.
Context is king in coding.
It really is. So we've talked about how coding impacts, you know, reimbursement research, public health initiatives.
It's all interconnected.
It's all connected. It's like a big web.
It's a web of data.
Yeah, and these codes are like the threads that hold it all together.
Exactly. But as we've emphasized throughout this deep dive, the world of medical coding is not static.
Right. It's constantly changing.
It's dynamic. It's always evolving.
That's what makes it so challenging.
It can be overwhelming.
How do we keep up?
The key is to cultivate a mindset of continuous learning.
So don't just rely on what we learned in school.
Exactly. Don't get complacent.
Stay curious.
Stay curious. Stay informed.
So what are some ways that we can stay up to date?
Well, there are a lot of resources available.
Like what?
Subscribe to industry newsletters, attend webinars, participate in professional development opportunities.
Okay.
And, of course, don't forget about that MCG manual.
Oh, yeah, our good friend, the MCG.
The MCG is a lifesaver when it comes to navigating those tricky guidelines.
Absolutely, and it's linked in the description.
It is.
So check it out if you need a little extra guidance.
And don't underestimate the power of networking and collaboration.
Oh, yeah. Talking to other coders.
Exactly. Connect with your peers. Share your experiences.
Learn from each other.
Learn from each other's insights.
Because we're all in this together.
We are a community of coding professionals.
Striving for accuracy and excellence.
Absolutely. So as we wrap up this deep dive, I want to leave you with this thought.
Okay.
Embrace the challenges of Neoplasm coding as opportunities for growth.
I like that.
The more we learn, the better equipped we are to advocate for accurate documentation, appropriate reimbursement, and ultimately improved patient care.
That's a great message to end on.
It's all about making a difference.
Well, thank you so much for joining us for this deep dive into the ICD-10-CM Chapter 2 Guidelines for Neoplasms.
It's been a pleasure.
We hope you've learned a lot and feel more confident in your coding skills.
Absolutely.
Until next time, stay curious, keep learning, and keep those coding skills sharp.